I want to just let you know that Dr. Castro is a clinical psychologist who's working at the Child Trauma Research Program at UCSF, ZSFGH, with her focus of clinical work has been working with immigrant families during the perinatal phase. She provides clinical services in the high-risk OBGYN, in the high-risk pediatric clinic, and in labor and delivery, and in the neonatal intensive care unit there. I just feel great pleasure and such a privilege to be able to welcome you, Gloria, back to training for us. So much appreciation, and welcome everyone. And I'll let you go ahead and take it away. Thank you, Dr. Castro.
Thank you very much for inviting me. It is a pleasure to be meeting with all of you this morning. And I hope that the material that we are going to be discussing is going to be useful for the type of work that you are doing right now. And one of the things that I would like to ask you is that I would like to invite you to feel free to stop me if you have questions or if you would like to make comments about the material that I am presenting, okay? You can also put it in the chat, but sometimes for me, managing everything at the same time is a little bit difficult, and I don't want to miss any of your comments or your questions, okay? So
I can help monitor that for you, Dr. Castro, the chat, and people raise their hands.
Okay, that would be good. Thank you very much, Beth. And right now, what I am going to do is to share my screen. Can you see my PowerPoint? Good, very good. Okay, so let's start talking a little bit about how important the first couple of years are going to be for the development and the growth of the child. And I think that what we are going to be listening throughout this morning is the importance, you know, of the attachment that children are going to establish with the primary caregivers. Young children are going to rely on their parents or their primary caregiver from protection in terms of when there is danger, that the primary caregiver will play the role of a secure shield. So that is very important. And also to start thinking a little bit about how when traumatic events are happening within the family system, even to the mom, something is happening to the mom or the father or another member of the family, you know, that traumatic event is going to have a huge impact on the core of what is the attachment, okay? So traumatic experiences are going to shatter the protective shield. That is the most important role that the parents are having, specifically during the early years. Okay, so let's talk a little bit about let me see, because a little bit about attachment theory and who was involved in the development of this theory. And one of them is John Bowlby, and he was one of the pioneers in the field who was saying that children develop attachment to their caregivers who are going to be taking care of the babies during the initial years. And what is important for us is to remember that this connection, this attachment between the primary caregiver and the infant is going to be the template for future relationships that the infant is going to have. That's why for us who are working with very young children, we pay a lot of attention in those early experiences because we know that that is going to have a huge impact in the development of other relationships. And so I want to introduce you to John Bowlby and to Mary Ainsworth, because they were the ones who really developed at the beginning the theory of attachment. And one of the things that we know based on the work that they were doing is that, let me explain to you a little bit about the work that Bowlby was doing in England. And he was working with a very young, very young people who were part of a lot of delinquent. Oh my God, I don't know what is happening to me. I'm so sorry. But what is important is that Bowlby worked with very young people who were doing a lot of things that were putting them at risk to be incarcerated later on. And one of the things that he found out is that all of these young people, one of the things that they were having in common was that all of them lost their mothers at a very early age, even if that loss was due to death or because the mother, for one reason or another, disappeared from the life of these children. And what Bowlby and one of his colleagues, Robertson, found out is that the way these young people responded to that was either via denial, that they were denying what was happening, or they were able to protest, to have behaviors that were letting them know that there was a lot of protest, but they were unable to articulate the impact of the loss of their parents. Or some of them were exhibiting a lot. For example, one of the things that Robertson was doing at the time was doing a lot of behavioral observations. And he was able to observe that some of these juvenile people, they were exhibiting a lot of despair because of what happened to the loss of their mothers. Then another thing that I would like to share with you, if you in the future have the possibility to read a little bit about what Bowlby did, he has 3 little books that are very good, and one of them is called, we call that the attachment. There are 3 books: the attachment one, the separation, and the loss. And he talks and he gives a lot of examples about the impact of attachment as well as the impact of separation between the infant and the primary caregiver. Okay. Bowlby was very interested in the bond between the parent and the infant. And as I was telling you before, he considered that this bond was going to be the template for future relationships. Then one of the things is that the connection between the primary caregiver and the infant is in itself very dynamic. Okay, it's not only the way the mother relates to the baby, but it's also the way the baby relates to the baby. And he was also very interested. Before we started, I was talking to Beth a little bit about the work that John Bowlby was doing with children who were separated when these children, very young children, needed a medical intervention and they had to be hospitalized. But at the time in England, this was in the early 50s, they were not allowed the parents to stay in the hospital with the children. And actually, all the work that John Bowlby and Robertson did, they contributed in a significant way at the level of the whole world to start thinking about how important it is not to separate children in hospitals and to start taking into consideration how important it is for the parents to be with their children during those moments. So on the other hand, we have Mary Ainsworth, and one of the things that Mary Ainsworth did was that she was the one who created a very particular procedure that we call the strange situation. And her idea was how she was going to be able to identify the different type of attachment that the child can have to the primary caregiver. And because of this procedure, she was able to classify that relationship between infants and children and their primary caregivers in secure or insecure attachment. And in terms of the insecure attachment, we have the organized insecure and the disorganized attachment. But she also talked about two important things. That was the parental sensitivity and also how appropriate the primary caregiver is in responding to the cues that the baby is sending to them, okay? And she observed the relationship between secure attachment and the confidence that the child has, the sense of feeling secure about leaving the mother in order to explore the environment that is around the infant. And what we learn about this strange situation procedure is how the infant is going to start, using the bond with the primary caregiver as a secure base, that the infant can go, he feels secure enough to go and explore the world, but at the same time, when he needs to be reassured or he needs to be protected, he can come back with the certainty that the primary caregiver, the mother or the father, are there and they will be able to help him, okay? So as I was telling you, this strange situation was developed in order to be able to classify the infant into one of the three attachment categories. Now, we are going to be able to show to you a little clip of how this procedure is done. And it has 8 episodes, okay, that are going to last more or less between 3 and 4 minutes. And we are going to have, I am going to ask you to pay attention that in the procedure, we are going to have the mother, the infant, and a stranger who is going to be introduced in the whole procedure. And also we are going to be, I want you to pay a lot of attention what is happening to the infant when first of all, when the stranger comes into the room, when the mother leaves the room, and when the mother comes into the room, and also to see how the infant is relating to the stranger in the room. So this is what I was explaining to you a little bit about that. And now let's focus before going into the little clip that we have for you. Let's talk about in itself about this procedure. And what it was important is that, as I was mentioning to you, there were 3 types of attachment that she was able to identify. The secure attachment that she calls type B, in which the children use their primary caregiver to explore the environment. Then the insecure avoidant, that it's called type A, that is that they do not look at their caregiver when exploring their environment, and they do not reach out to the attachment figure, that means the mother, when they are in distress. They are avoiding that. In terms of the insecure ambivalent or resistant that she called the type C, what happened is that the infant is going to display ambivalent behavior towards the primary caregiver, and they are not going to be comforted by the caregiver. They often show this kind of, at some points, they look at the attachment figure, but at some times, you know, they really reject the primary caregiver, you know. So there is a lot of ambivalence to get close to the mother and to, at the same time, be resistant to be soothed by the mother. What I did in here was that I included this box in which you will be able to see how the secure, the resistant, and the avoidant type are going to respond to the separation. Okay, in terms of the secure, we are going to see that the baby is going to show distress when the mother is leaving. And in terms of the resistant, there is going to be intense distress when the mother leaves. And with the avoidant, I want you to see how with the avoidant type, they are going to show no sign of distress when the person who is a stranger, and when the mother leaves, and they are going to stay with a stranger. Now, with the secure babies, in terms of the stranger anxiety, what we are going to see is that the secure babies are going to avoid the stranger person when they are alone, but they are going to be friendly when the mother is present, because what the baby is doing is using the mom as a social reference, you know, and that is something very, very important. With the resistance, the infant is going to avoid the stranger, and sometimes they are going to show fear of the stranger, okay? And with the avoidant, the infant is okay with the stranger and plays completely in a normal way when the stranger is present. And I want you to think a lot about this, especially I noticed that when we were learning at the beginning who is part of this particular training, there are people who work in daycare or in a preschool. I think that for us, you know, for many years, I was able to provide infant mental health consultation in a daycare and in a preschool in San Francisco. And I think that this, when I was observing the children, for me was very important to see what was happening with the children when they were left in the daycare and how they responded to the people who were going to be taking care of them during the day. And then what happened with these infants when the mother comes back and they have the possibility to join the mother again. Because in doing that type of observations in daycares or in preschool, we can start having an idea how is that attachment that the child is having with the primary caregiver, okay? Now, let's continue with the strength situation procedure. When the mother comes back, in terms of the secure attachment babies, we are going to see that the reunion is very positive and they show like they are very excited and happy when the mother returns. With the resistant babies, we see that the infant approaches the mother but resists some type of contact with the mom. And even if the mom tries to get close to the baby is going sometimes even to push away. When we are looking at the avoidant babies, what we will see is that the baby is not going to show any interest in the mother, okay, when the mother returns. And here we put in other situations how the mother uses, the child is going to use the mother as a safe base to explore the environment, as I was mentioning to you. And in the type of resistant infants, you know, the infant is going to cry more and explore less than the other two types. And with the avoidant, the mother and the stranger are able to comfort the infant in the same way, okay? So that is telling us a lot about what is happening. Right now, I would like to stop for a while, because I would like to invite you to think a little bit about what I just mentioned to you and how that information is landing on you. I want to hear if you have comments or if you have some questions or some thoughts that you would like to share with all of us before we continue.
There was one question Gloria asked about the strange situation in fathers as caregivers and what research has been done around that.
Oh, it's exactly the same, because sometimes, and probably some of you have had this experience, that the primary caregiver of the baby is a father, is not a mother. And I can share with you that when I have been doing a lot of infant mental health consultation in the NICU or at the birth center at San Francisco General Hospital, one of the things that I have noticed is that a couple of months ago, I had a very sad case in which the whole complication of the pregnancy got to the point in which the mother, after delivering the baby, she needed to go to the intensive care unit, and unfortunately, the mother passed away. And so we had this father with this new baby. And so I was able to continue providing therapeutic support after, for a couple of months to this father. And it was, very sad, the whole situation, but it was very interesting how this particular baby was developing a very secure attachment with the father. Okay, so, and when we are talking about attachment, I want you to think about that is not only the primary caregiver can be a mother, a father, a maternal or paternal grandmother, and the thing is like Winnicott, that was a pediatrician and also a psychoanalyst, he used to say there is no such thing as a baby. And what he meant is that the baby, we need to conceptualize this baby under the care or another adult. And it can be mother, father, or whoever. But the baby needs that type of attachment with another figure who is going to be taking care of him. Mm-hmm.
And there's another question about is there any recent research on attachment since Bowlby and Ainsworth's? Their research was so long ago. And are there criticisms about their work?
Okay, yes. Of course, there is a lot of research that has been happening, since the 50s, the early 50s. Okay, and yes, there has been a lot of people do not like the strange situation procedure, and the reason is because they have been talking a lot about how do we expose an infant to this particular stressful situation. So yes, there has been a lot of people who have criticized that. But on the other hand, we have had a lot of research about very recently, and I have the opportunity to be working right now at Child Trauma Research Program, and that is part of UCSF. And a lot of the research that Alicia Lieberman has been, who is the director of the program, and all her colleagues that are focused on research, what they have been doing is how the impact of certain traumatic experiences, like for example, what happened to a child from 0 to 5 when he has been witnessing domestic violence, or when the child has been exposed to physical abuse, and what happened with the attachment and the role that a secure attachment is playing in terms of buffering the traumatic experiences on the child. Okay, so yes, there is a lot of research that has been happening in the last couple of years, and yes, it's very important what Michelle was saying in terms of ACEs. And actually, let me share with you that right now that I am beginning, as I was mentioning to you, Beth, doing the training in perinatal child-parent psychotherapy. One of the things that we are doing is to identify the ACEs, because the number of ACEs that the mother has had in the past is going to have a huge impact in the well-being of the baby because of the type of relationship that they are going to be having. And what we are doing with this particular model that we call perinatal CPP is that one of our goals is to enhance a secure attachment between the mothers, that we begin to see them during pregnancy, and then when the baby is born, we are going to enhance the secure attachment as well as the reflective maternal functioning. What is the meaning of that? That the baby will be, the mother will be able to understand the internal state of the mom. Okay, we support mothers to be able to look at their babies and to be able to read the cues that the baby is sending to the mom. And do you remember when I was talking at the beginning, how important is that the mother is going to be able, first of all, to identify the needs of the baby, to read the cues that the baby is sending to her, and the other thing is to respond in an appropriate way to those needs that the baby is having. Do you have other questions or other comments?
There's one other question about wondering about this research in diverse communities of color, LGBTQ families as well, and yeah.
Yeah, and let me explain to you a lot of what we do, and probably you are in the same situation that I am, that we work with a very a community that is very diverse in terms of culture, okay? And I think that what is happening is that my sense is that this attachment, the concept of attachment, that is the capacity that the mother is going to provide what is needed so the baby is going to be close to the mom and use, and I am using mom, but it can be another person, but that the baby is going to use that relationship as a secure base in order to go and start exploring the world. That is something that is universal. Okay, what is important for us, and depending on the type of work that clinical work, for example, or not only clinical work, but I am talking about, for example, the care providers in a nurse, in preschool or in a daycare. What you are going to see is that the culture in which this child, very young child, is embedded is going to play an important role. Okay, but the connection with the primary caregiver is fundamental, is crucial in order for the baby or the child to be able to survive.
Thank you.
Okay, so let's see if we can continue. So the most important thing about the work of Bowlby and Robertson and Maine and many other people who have been working in this field is that based on that research, we have been able to develop particular clinical interventions to make sure that the children are going to be able to have a secure attachment with their primary caregivers. And at the end, I am going to be talking about some of these modalities of treatment that we are using to enhance the secure attachment. But thanks to this particular research, that's why we were able to develop all the clinical interventions, okay? Now, here, I organized this because I think that I would like to, in a very visual way, to see how the primary care's behavior toward the child is so important, okay? Because it's based on that interaction between the mother and the child is going to develop something that we people who are doing mental health work, we call the internal working model, okay? That means that the child in that relationship is going to be able to develop a sense of self, okay? And the way the baby is going to develop that sense of self can be that I am someone who is lovable, I am a positive individual, or probably I am not, I am unloved, and also people are rejecting me, or I am very angry and I am completely confused. When I am feeling like this as a child, you know, this is what is happening. The child is having a resistant type of attachment. When the child is feeling unlovable and rejected, we have here that the child is having an attachment that we call avoidant. And when a child is having a sense of self in which he sees as a positive individual and that he is someone who is loved by other people, we know that this is a child who has developed a secure attachment, okay? So the internal working models are very, very important. Our idea when we are working with pregnant women is that, and I am going to share a little bit of this, is that during the second trimester, for example, the woman is going to talk a little bit, is going to think a little bit about the symbolic baby, okay? And in that particular developmental stage of pregnancy, women are going to actually to their babies who are not born yet, a lot of things that do not have to do anything with the baby, but they have to do with the working model that the mom has and has established, okay? So that's why to be able to work with these moms even before the baby is born is so important, very important for the mom and for the mental health of the baby, okay? Another thing that happened was that Mary Main moved the study of attachment to the level of representation, okay? And what she worked a lot on helping the parents, mothers and fathers, to be able to construct a narrative about how they were describing their own childhood, okay? How they were describing the way they were connected with their parents. And what she found out is that she was able to identify a secure autonomous pattern, a dismissing, or a preoccupied, and something that she called the approach avoidance dilemma, that it was in a way unresolved. And I think that is important because we began to see, you know, how the parent, on one hand, we understand how the child is going to need that connection, emotional connection with the primary caregiver. But on the other hand, we need to understand that this primary caregiver, this parent, has also an experience of connecting or not connecting with their primary caregivers. So that was something that it was very important for us, people who work in as clinicians, to be able to understand. Okay. So now I would like to think a little bit about all the people who are this morning with us, that you are in one way or another related in your work with children who are very young, right? And their families. Even if you do home, for example, if you do home visits as clinicians or as a family advocate, or if you work in preschools or in daycares, or if you do psychotherapy. But I would like to highlight this. The most important thing in the therapeutic alliance is to be able to give that particular individual, either if it's an adult or if it's a child, to be able to create a secure relationship, a secure working alliance with that individual, to give them, for example, if I am a teacher and I am working with a mother of this particular child, as a teacher, I want to establish a relationship with the parent of this child, so that parent can experience what is the meaning of feeling safe in a relationship. Another thing that is going to be very important for our job is to instill trust, that the families with whom we are working, they can begin to develop this trusting relationship. And another thing is to enhance mentalizing skills. What is the meaning of this? When we are working with children, it will be very important for us to help the parents to think a little bit about how they think that is the experience that the child is in this particular moment. And I think that that is important. I don't know if someone had a question.
There was a question about our country and having infants as young as 6 weeks going into childcare. Mm-hmm. And how does this affect a secure attachment?
Yeah, and it's a very important question, and I would like to answer the question in this way, Ellen. I think that what is going to buffer the separation is going to be the quality of attachment that the mother has been, the child has been establishing with the mom, with the support of the mom, okay? And even you are talking about babies who are as young as 6 weeks. For example, and this is something that is part of my clinical work. As I was mentioning to you, right now I am working with pregnant women. Well, we don't talk about the baby. We talk to the baby even before the baby is born. The type of work that I do is a dyadic work, and the baby is an active participant of the treatment. And so one of the things that we encounter with the population that we are working is that the parents need to go back to work. So they need to find a daycare for the baby. So it's how we are going to prepare the mom or the dad about that transition, and how we are going to anticipate what might be happening, because the most important thing is for this mom or this dad to be able to support the baby for doing that transition. Okay, so that doesn't mean, and this is something that we need to be very careful, because the message that I want to send to the parents is not that, oh my God, you are doing so bad, and your child is going to be impacted in a negative way because you are separating him from you at an early age. The most important thing is what happened with these parents before they leave the kid in the daycare and when they reunify with the child. Okay, I think that that is very important to anticipate to the 6 weeks old baby, you know, what is going to happen, who is going to take you, and to be able to say goodbye to the baby in the best situation. When I am working with parents who need to go back to their job very early, you know, after they deliver the baby, I think that the most important thing is for me to support the parents, so the parent is not going to be able to identify the internal experience of the parent and work with that. So he or she will not transfer those intense feelings and guilt to the child. I don't know if that answered your question, Ellen.
Yes, it very much answered my question. Thank you.
Okay, so let's go and see and continue. Okay. Okay. So this is something that I was telling you that is very important in every relationship that we are going to establish with the primary caregiver of a child from 0 to 5. And I could say even after 5 years old. So let's do a little bit of a summary here. And we have here that how attachment refers to the observation from the start of life. And this is common with other mammals, not only with human beings, okay? And how we develop important relationships with those who protect us and care for us. The challenge here is that when my primary caregiver is unable, because he or she has mental health issues, is unable to protect me. And that is when we need to intervene, okay? Because that is going to be very important for the infant. And these connections are motivated by infants' drive to survive. This initial connection with mom or dad or the adult who is going to care for me is important, because if I don't make that connection, I won't be able to survive, okay? And all of this is going to be maintained by the parents. And if you see in every single interaction that happens throughout the day, because that doesn't mean that there are not going to be mismatches. Of course, we are humans and there are going to be moments in which there is going to be a mismatch. But the most important thing is that we, the adult, we need to help that adult to be able to repair that mismatch. And then we have been talking a little bit about the secure base and how the secure base is going to be very important for the child, not only to go and explore the world, but also when there is a threat, or the child is very stressed, or the child is sick, how important is the secure base? Because the child will be able to come back to that base with the experience that I will be suited in that particular moment, okay? When we see anxiety disorders in children and in adults, we need to think about this like responses to trauma or failure of parents to provide safety, because that is the most important role that the parents are having. And also we have seen how Bowlby conceptualized anger and violence to self and to others as pathological manifestations of healthy protest. part of normal response to the separation. Okay. Now I am going to be able to share with you this little clip, and you will see that this happened, I think that many years ago, okay? And
but can the essential elements of home life be translated into a standard laboratory setting for controlled scientific study? After conducting extensive observations of parents and children at home, a student of Bowlby's, Mary Ainsworth, devised such a procedure called the strange situation, which places the child under some stress. It has become the most widely used standardized way to assess the quality of a child's attachment to their caregiver. Here the researchers are recording how 14-month-old Lisa responds in this attractive but unfamiliar setting. How will she react to a stranger? What will happen when her mother leaves the room? And when she returns? It's Lisa's behavior when her mother returns, what psychologists call the reunion, that they are particularly interested in.
Most importantly is to look for the type of balance that a child strikes between an attachment need and, on the other hand, to explore the play material.
Once Lisa has settled down to play, a stranger enters the room and sits in the chair reading a magazine.
Lisa, where's the bow? Where's the bow?
After a couple of minutes, the stranger attempts to interact with Lisa. Soon after, Lisbeth gets a cue to leave the room. The stranger tries to comfort Lisa, but in vain. Lisbeth comes back into the room, and the camera records how Lisa reacts. Now the first part of the procedure is over, and Lisbeth settles Lisa down again. The stranger leaves them alone together. And soon after, Lisbeth goes too. Lisa is on her own. Her distress is plain to see. Once again, the efforts of the stranger to console Lisa are to no avail. But Lisbeth manages to calm her almost at once, and shortly afterwards the observation ends. Lisa showed outward signs of what's called secure attachment.
okay. I would like to make a pause and to, to talk a little bit about how was for you to watch this video clip, and how do you think that the information that we have been talking about is related to the work that you are doing right now? I would like to hear, and I would like to invite you to, if it's possible, to show, to turn on your screen so I can have a sense of all of you. Thank you. So I would like to ask you a little bit if you think that this type of information that we have been discussing this morning is helping you to see your work through a different lens.
Feel free to unmute yourself if you want to, if you have something.
Mhm.
I could say something, but I've already asked a few questions, so I want to give other
That's
people a
okay.
chance.
That's okay.
Because
Ellen.
mine's a little different. I'm actually teaching child development, to college students out at a community college. And when we read about attachment in the textbook and when we cover some of this information, what happens is a lot of the college students are now confronting their own childhood, and maybe they're recognizing that they themselves didn't have a secure attachment. And so this could be any adult, so we wouldn't have to be college students, and you learn about it and it can be very upsetting. So I have students, and I'm not a therapist, who tell me in their discussion posts or, other written work that it brings up a lot of really, troubling reality for them, that they see the reason why maybe they don't have trust in relationships now, or why they push people away, is connecting to their. I just wonder if you have any advice sort of on how to let people know. I think something on one of your slides said, there's still hope, or you can still work on this as an adult, or it's not set in stone because you maybe didn't get that secure attachment as a child, and now you're an adult and you're starting to have that self-understanding of what happened in the relationship with your own parents. How can we help them? What do you have any tips?
Yes, Ellen, that is a very good question. And I am going to tell you this. Throughout the years that I have been doing this work, with families with very young children, one of the things that I have learned in my clinical work is that the only way we can avoid passing trauma or psychopathology from one generation to another one, the step number one is to become aware. And when your students are sharing with you, now I am beginning to understand why I cannot trust, how come I cannot develop certain type of relationships. Now I understand, because I do not trust people, okay? And for me, as a clinician, I can say, this person is able to understand, beginning to understand his internal working models, okay? What I learned from my primary relationships with my primary caregivers, okay? And that is the first thing, to become aware. And I am going to share with you, that as I was mentioning to you, I am doing a lot of work in terms of the perinatal developmental stage. So we want to intervene even before the infant is born. And I have been doing a lot of presentations about that work. And I just finished the first learning collaborative in this particular work. And one of the things that I noticed, that the people who were attending, was that they were triggered by the presentation, because they became aware of how they experienced their pregnancies and their deliveries, or the histories that they have heard in the past from their parents about when her mother was pregnant, and the narrative that mother constructed about giving birth to this particular person who right now is sitting down listening to my presentation. And the way I always respond to that is, this is amazing, because self-understanding, and getting to know ourselves is important, and is the first step to stop transmitting from one generation the trauma or patterns of interaction, Ellen? Because the patterns of interaction of insecure attachment, those are passed from one generation to another one. And the only way we can prevent that is for the individual to be able to become aware. Does that make sense?
Oh yeah, that's so helpful. I took down so many notes because, you know, when I respond, I do want to say something like this, you know, that, and so that's, I think, very important, you know, to, like you said, say, you know, this is a first step, and this is really important because your self-understanding, you know, everything you said there can be, you know, a way to, stop transmission of patterns of interaction. So I got it all written down. So that'll be very helpful. Thank you.
Okay, very good. What about other people? What came up for you in what I have been talking in relationship to the work that you are doing? Does this make sense or not?
I have a comment I'd like to make. You know, when I started out as a new therapist, I had more of a fascination and an academic interest when I would watch the attachment videos. The longer I've worked in the field, the harder it has become for me actually to tolerate that. And as soon as the baby starts to cry, I have a visceral reaction to that sound. And it could be that I've had more kids since I became a therapist, but I don't know that that's why particularly. But now I've noticed that same reaction when I'm out in public, and I immediately start to look for the cues around how the mom, or the caregiver, I should say, the caregiver is reacting to the baby when they're having that, or the young child. So it's just, I don't know if it's vicarious traumatization as a result of working in the field long enough, but I would be curious to see what your thoughts are about that for people who, as they move through, the longer they spend working in this, how to manage to that.
Mm-hmm. You know, Jennifer, that is true. The more clinical work you do, you begin, even when you are not in your clinical setting, if you are in a park, a lot of the things that I tell my interns, my postdoctoral fellows who are working with me, is go to the park, because right now we cannot go make observations in the NICU or in the nursery because we are not allowed to do the work there. And I have been telling them, you really need to learn how to make behavioral observations. So go to the park and observe moms with very young children and observe how the children are sending constantly signals to the primary caregivers about what they need and how the parents are responding to them. And yes, it is very difficult, Jennifer, you are right, to watch that. I have been in situations in which I have been in the Children's Health Center at San Francisco General Hospital, working with the mom and the mom with twins. And the mom is having a lot of negative attributions to one of the twins, and she's paying more attention to the other twin. And in the room, you know, I am noticing how one of the twins makes a little bit of a movement or sound, and the mother responds to that twin. And the other one is crying, sobbing, and the mother does not respond to that. And when I am with one of my interns in the room, that I have been in situations in which the intern wants to pick up the baby and to console, to soothe the baby. And we don't do that. Why? And it's very difficult for us, okay? Because the cry of the baby is going to trigger intense feelings and also intense memories about our own history. And the reason why we don't go and we pick up the baby is because we don't want to send the message to the mom that she's not a good enough mom. And that I am the one, the expert who is going to soothe the baby. In those particular situations, what we can do is to name and to give voice to the baby by saying, wow, little Johnny, I'm noticing that right now you are in a lot of distress. And I am wondering how it could be for you if mommy would be holding you. So my intervention is to the baby, not to the mom, and to see if the mom is able to take in that intervention. But you are right, is that, and we need to be very careful with ourselves about taking care of ourselves when we are doing this work. Okay, I don't know if that was helpful.
It was. Thank you very much.
Okay, and I know that there was another person who wanted to make a comment.
Yes, that was me. I am working with mostly 3 to 6 year olds at this time, and in kind of a social and emotional learning environment. And attachment has always kind of been in the back of my mind when it comes to when the kids are being dropped off or when they're being picked up, and how every kid has their different attachment styles, which means every kid is different with how they warm up to the learning environment and things like that. And so I think that learning more about the attachment styles really helps us hone into what kind of coping mechanisms do these kids have, how can we build up resilience when it comes to detaching from parents, or even going back to like when they're being picked up by mom and dad. So I think all of this information is really helpful.
Oh, I'm so happy to hear that, Janelle. Thank you. So let's go back and then we can continue with this, okay? Let me see where, okay. So now I would like to share with you that there is another type of attachment that also is considered insecure. And this came up when a lot of research was done about the impact of trauma on the development of these very early relationships. And this is what we call, the disorganized attachment. And it's a combination of avoidant and anxious attachment. And children are going to display a lot of anger and a lot of rage. This is something that we can see, for example, in daycares or in the preschool, when children, the teachers, I remember that they used to complain that so-and-so all the time he's breaking the toys, he's throwing toys away, things like that. There is a lot of rage, and I want us to remember that under the rage is a lot of pain, okay? So, and these children with this type of attachment has a lot of difficulties in establishing relationships, okay? And they are going to tend to avoid intimate relationships with other adults, and later on, they are going to be the people who are going to explode and have a difficult time controlling, regulating the intensity of their emotions, okay? And that's why it's important to look at this. For example, in a couple of weeks, I am going to be talking a little bit about the different type of disorders that we can see, like depression, anxiety, PTSD, things like that. And I can tell you that a lot of people with bipolar disorder that I have been working with them, they have the disorganized attachment pattern, okay? It's important for us to begin putting together the different pieces of all of this. We need to live this morning, with the idea that securely attachment infants are those whose mothers are very sensitive, and they are going to be able to identify the needs of their child and to be able to respond in a sensitive way and in a very appropriate way to the needs of the child. Okay, so this is important to keep in mind. Then we have the attachment caregiving system. Okay, so we know that there is a biological predisposition to seek out their caregiver for protection from that danger. That is the biological base of the attachment system, okay? The pattern of caregivers' responsiveness teaches the child the degree to which they can consistently rely on their caregivers to relieve their fears and to ensure safety. So the caregivers who are responsive to the distress of their children, you know, the children are going to tend to develop a secure attachment relationship. But those who are parents who are neglectful and rejecting or inconsistent, the children are going to develop an insecure attachment relationship. And we have been talking a lot about how these primary relationships are going to set up the foundation for future patterns of interaction. Okay. So just as a summary, the caregivers who are responsive to the distress of the child, these children tend to develop a secure attachment relationship. Okay. For example, what happens if we see a toddler who is trying to ride a tricycle and the toddler falls down? We need to pay a lot of attention how the mother is going to respond. And we are going to see sometimes how the child is going to turn around and look at the mom or the father as a social reference. And depending on the way the parents are going to respond to the fall, the child is going to react or to respond. Okay, so a mom who sees the child who is falling down and she says, "Are you okay? Do you need help?" Versus the mom who is going to be in panic and is going to start yelling, "Oh my God, I told you not to ride the tricycle because you don't know yet, blah, 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 blah." That child is not going to use that secure base. You know, actually, he doesn't have the secure base to go and get comforted from the primary caregiver, okay? So another thing that is, for us is to remember that frightening events, one of the things that can have is that they are going to dysregulate the parent-child relationship by triggering post-traumatic stress reactions, not only in the child, but also in the adult, okay? That's why it's important when, for example, even in the best circumstances, and the child has developed a very secure attachment with the mom, but they have been exposed, let's say, to a very violent traumatic event coming from the father, let's say. In those moments, the mom, that relationship is going to be impacted, okay? And that's why it's important to support the adult. So the adult will be able to regain the sense of agency to protect her child and to make sure that the child is feeling fine, is feeling okay. And that is a lot of what is done with dyadic type of therapeutic interventions, you know, to be able to work with that relationship, okay? And also the frightening events can prevent the child to be able to seek comfort from the parent. And this is, we need to understand that with the lens of trauma. The whole traumatic event has been impacting the whole attachment system. So here, what I included was how traumatic experiences are going to have a huge impact on the core of the attachment, that is the protective shield that is going to be shattered, okay? The mom or the dad cannot be used as a protective shield in that particular situation. Children who have been able to develop a secure attachment relationship, they are going to be able to trust others and to trust that other people, even if the parents are not available, emotionally available at one point, they will be able to use another adult relationships to regain the sense of being safe, because that's what they have been learning. Then I include here some of the indicators of secure attachment, from 1 month to 18 months. And I included the child's behavior and the parent's behavior. So the child is going to send a signal and relaxes when his or her needs are met. What the parent is going to be doing is to respond to the baby signals and to respond to those signals in most of the time. We cannot say that all the time the mom is going to be available. But remember, when those mismatches happen, the primary caregiver can go back and will be able to repair that rupture. The child is responsive. That means that the child is going to have a wide range of emotions, and that the parent is going to be able to tolerate the intensity of those emotions, okay? And helping the child to, if the child at some point becomes dysregulated, the parent's behavior is going to tend to be one in which the parent is going to help to co-regulate with the child, so the child could come to the baseline, okay? Another thing that we have been talking about is how the children with secure attachment are going to look back at the parents to be reassured when there are situations that they do not understand. They do not understand, for example, when there are strangers that are coming home and they don't know who they are, and how the parents are going to introduce those strangers, and they are going to be able to be very nurturing and to help the child to understand that this person is also someone that they can trust, okay? And when the child has a lot of anxiety or anger or a flattened affect when the parents leave, the parents' behavior, and this is what I was telling you before, is going to be very important, how the parents are going to anticipate the fact that they are going to leave. In the past, a lot of the parents, at some point, they wanted to go to the movies and they were going to leave the baby with a grandparent or another person. And instead of explaining to the child what is going to happen, that we are going and we are coming back, and anticipate to the baby or the child everything, they tended to distract the child. That is not a very good idea. So we have seen that the indicators of secure attachment, how the moment in which the parent comes back into the room and is reunited with the child, not only the child is going to be feeling, soothed and calm, but also we are going to see how the parent is making eye contact with the child and is calling the child by his or her name, okay? All of this is helping the child really to be able to start feeling better when the mom is coming back, okay? He has the ability to do that. And at the same time, the parent is going to encourage the baby to be able to explore the environment in a safe way. And here, I am included some of the indicators later on in the development of the child, when between 18 months and 5 years of age. And what we see is that the child is going to handle longer periods of separation without being disorganized from an emotional point of view. They are going to increase their ability to accept redirection and discipline and authority, okay? They are going to show empathy later on, not at 18 months, but later on, and remorse, and they begin to start experiencing guilt. And they are going to use and I want to be very careful about this, that they use coercion to influence parents, because I don't want sometimes a lot of the parents are going to tell you, for example, my 2-month-old baby is manipulating me. My 2-month-old baby is doing this particular thing on purpose. So, and we need to be very careful to help the parent try to understand what is the meaning of that behavior, rather than naming the behavior as the child is manipulating me, okay? So an adult behavior, how that is going to be, the parents are going to be responsive to the cues of the babies. They are going to encourage growing autonomy and praises and accomplishments. And they are going to be able to redirect the behavior of the child, or they are going to be able to set limits when that is important, and specifically in relationship to safety issues, okay? Another thing that is important for us to be able to witness with the secure attachment is that there is going to be intimacy, and the parents and the child, they are going to enjoy those interactions between the two of them. So here, the ability to recover from traumatic experiences is going to be influenced from the quality of the attachment that the parent has been able to establish. Another thing that is important is that the early interventions that focus on relationships are going to be the best interventions for these particular children who have developed insecure attachments, okay? And I would like just to name a little bit about the pioneers in infant mental health. We have Selma Fraiberg, who has a beautiful article that I really encourage you to read, that is Ghost in the Nursery, that she talks about the transgenerational effects of trauma on infants, and how the psychopathology is transferred from one generation to another one. On the other hand, Alicia Lieberman wrote another article that is the counterpart of Ghosts in the Nursery, that it's called Angels in the Nursery, who is in that article, she explores the beneficial effects of good parent relationships. And when we are talking about, he talks about benevolent memories, even if the child did not have a secure attachment, how we can help the child or the adult, if we are working with adults, to try to remember, benevolent moments that she or he had. And that doesn't mean that they were related to the primary caregiver, the mom, but sometimes adults are talking about their experience, for example, with their maternal or paternal grandmother, to give you an example, okay? And for example, Sander and Daniel Stern, they talk a lot about, they have a beautiful book that it's called The Interpersonal World of the Infant, and they suggest that caregiver relationships could alter the course of the child's development and future ability to form healthy and adaptive relationships. So as you can see, the attachment is going to be very, very important. Now, let me well, we have been talking a lot about the adult attachment interview that became a critical technological breakthrough that offers a standardized tool for looking at parents' working models. Okay, she developed this particular interview in order to identify, you know, the narratives that the parents were having, the adults were having in relationship to their primary caregivers. And so that's why this type of work is very, very important. Okay, now I would.
Can I ask a question, Dr. Castro, about the adult attachment interview?
Yeah, sure.
I'm wondering, is that a tool? I mean, is it a tool that one is, how deep is it? Is it a tool that can be used by a psychotherapist? Are they trained in it? Anyway, I was just curious about your thoughts about, and do you use that tool?
No, I don't use that tool, Beth, and I am going to explain to you why. First of all, because in order to use that interview, you need to be trained in a particular way, and I haven't been able to take that train. And I think that the work that I have been doing at the beginning at the infant parent program and now with perinatal child-parent psychotherapy has given me another set of tools to be able to get the information that I need.
Yeah.
So you don't need to use that interview to do that, to support. The way I look at this is, for me, what is important is how I am going to provide to this particular parent or to this particular child the experience of being in a healthy relationship in which they are going to feel safe, that they can trust me, and that I am going to help the parent to start thinking about, you know, how they think that is what their child is going through. To imagine how the child is experiencing this particular situation. For me, that is what is the most important thing.
Thank you.
Mm-hmm. So right now, I would like to talk to you a little bit about some of the clinical interventions that promote attachment. Okay, these are only some of them. As I was telling you, the infant parent psychotherapy or the child parent psychotherapy or the perinatal child parent psychotherapy. With these three interventions that I am explaining here, what is very important to keep in mind is that we can intervene, we can develop clinical interventions directed towards the mom or the primary caregiver or towards the child, but always in our mind to keep the idea that what is important are two things: the relationship between infant, child, and parent, that is the important thing. And another thing that I want to mention to you, another piece that is very important is the development of the child. Because if these three interventions are good, what we are going to do to see is that development and growth of the child are going to be on target. And that is the most important thing, to think about the different developmental domains that the child will be able to achieve as expected. So for me, those two things are very important: the relationship with the child and the development of the child. Okay, the dyadic interventions, what is important is that they are going to address the pregnant person, if you get them when they are pregnant, or the parenting person within the family context, okay? And also we are going to address the baby or the child. We are going to, these interventions cover or resonate between generations. So we are going to be addressing the internal world of the parents, the internal world of the infant or the child, and the emerging present moment to moment relationship. And this is going to lay the foundation for the unfolding of relationships into the future. That's the beautiful thing about this type of interventions. There is another intervention that is called circle of security that I think that is very important, and the focus is also on attachment. And you will see here, for example, the secure base, you know, how the child leaves the parent. And what is important is that the parent is going to support the exploration of the child. And then the child here is exploring the world, and the parent over here is watching over the child, but not only ready to help the child, but also to enjoy with the child the exploration that the child is doing, and is delighted, the parent, in the exploration that the child is doing. And then the child needs to be welcomed to the safe haven when she needs to be reassured, okay? So the secure base and the safe haven, that means the secure attachment in reality has to do with protect the child, comfort the child, delight in the child, and or help the co-regulation or the organization of the feelings of the child. So I think that this one is very important, the circle of security. And again, the goals of this particular intervention is to increase the sensitivity and the appropriate way in which the adult is responding to the child's signals relevant to the child's moving away to explore and moving back to be comforted and soothed. Also is going to increase their ability to reflect on their own and the child's behavior, thoughts, and feelings regarding the attachment caregiver interactions. And they are going to reflect on experiences in their own histories that affect their current caregiving partners. And that's why I think that, let me stop here a little bit, because I would like to go back to all of you. That's why when Ellen was sharing with us about some of the comments that her students were doing, it's important for us to be able to respond. You know, how even if we did not have the opportunity to have that particular secure attachment, the fact that we are aware and that we can identify that we lack of that is the beginning of a healing process, and the beginning of trying to go inside myself to try to understand what I need in order to start developing safety relationships and relationships in which I am going to enjoy and feel safe, and that I can trust the other people. Okay, so we have only a couple of more slides that I would like to share with you. But before going there, I would like to ask you if you have comments or questions or thoughts that you would like to share with the whole group.
I'll make the comment that I made before we started, Gloria. We were talking about the fan training, and it reminded me, someone, I can't remember who it was, someone talked about their own dysregulation when they hear a baby crying or in how it seems to gotten worse as they've gone in their career. And having your own children, all of those things, kind of, and how provocative this work is, and how that is. Leah and I have been talking about trying to see if we could bring that training here, because for anybody working with kids, I think it can be a helpful thing.
Yeah.
Anyway.
And I think that that is very important, you know, to be, if we're working with young children, one of the things that we need to keep in our mind is that interacting with very young children is going to trigger a lot of intense memories and feelings related to us. And so it's important to take care of ourselves. And there are how we can, you know, when we begin to notice that I am dysregulating myself, you know, what I can do in the moment to be more grounded in the here and now. And in my case, for example, I use a lot of deep breathing, you know, and to be able to position my body in a particular way in which my feet are very grounded on the floor, you know. And right now that we are working, in my case, I am working from home, to be in a place in which I can lay my arms, you know, and so I need to start with my body. And once I scan my whole body and I start to take use deep breathing techniques, that helps me to modulate a little bit the intensity of my feelings in the moment. Okay.
Thank you.
So let's finish with this. Okay, so we talk about the goals of the circle of security. Now I am going to be talking a little bit about infant parent psychotherapy, and I was talking to you a little bit about Fraiberg and her colleagues, the article that she wrote that it's called Ghost in the Nursery. But I would like for us to read this piece of the article because I think that is beautiful. And it says, in every nursery, there are ghosts. They are the visitors from the unremembered past of the parents, the uninvited guests at the christening. Under favorable circumstances, these unfriendly and unbidden spirits are banished from the nursery and return to their dwelling place. The baby makes his own imperative claim upon parental love, and in a strict analogy with the fairy tales, the bonds of love protect the child and his parents against the intruders. Okay, so I think that this piece is important for us because all of us, as being human beings, we are going to have ghosts. There were some ghosts in our nursery, and it's important to be able to identify that. It sometimes happens, as Ellen was sharing with us, in a class that we are taking in a community college or at the university, and that is going to trigger a lot of questions for us. It's important to be open to all of this. In terms of child-parent psychotherapy, we have like a couple, like 5 premises. One of them is that the attachment system is the main organizer of children's response to danger and safety in the first 5 years of life. Another one is that emotional and behavioral problems in infancy and early childhood are best addressed in the context of the child's primary attachment. And that's why it's important if we are going to provide clinical interventions, they need to be dyadic, okay? Specifically with children from 0 to 5. And then the number 3 is that the cultural and socioeconomic ecology of the family must be an integral component of clinical formulations and treatment plans. Okay. And the number 4 is that interpersonal violence is a traumatic stressor that is going to have a specific pathogenic repercussions on those who witnessed it and on those who experience it. And the last 2 are that the therapeutic relationship is a fundamental mutative factor in treatment. And that's what I was telling you, how in the relationship with in treatment, that relationship is going to be offering the individual probably for the first time, the experience of being in a relationship in which they can feel safe and that they can trust us. And then the last one includes speaking the unspeakable while promoting safety and hope. And I am going to talk to you a little bit about speaking the unspeakable, because what this means is how important it is to name what is happening, the trauma, the traumatic experiences that the individual is having. That is what we call speaking the unspeakable, you know. For example, I would like to go back a little bit to what Helen was saying, because that was a beautiful example, is that the student is telling her, you know, this is what I think is happening to me. And for the professor to be able to name that and to say, yes, I am hearing, and it seems that this is something that you are beginning to try, or you are trying to understand, that is speaking the unspeakable. Do not have a fear about naming what we are noticing. And then I think that right now we are not going to have a lot of time to talk about a clinical vignette, but I think that what is important for all of us in the type of work that we are doing, and in this particular group, we have family advocates, home visitors, professors, a lot of people who are working in the daycare or in the preschool. And what is important is always to notice feelings in the moment. As I was talking to you before, to speak the unspeakable and use concrete words to describe the traumatic experiences that these people have gone through, and find connections between experiences. For example, why right now, when I am working with this mom and the mom is letting the baby to cry and she's not paying attention to the signals that the mother is sending to the baby, why I am beginning to feel very anxious. I need to make connections between my own history that I am holding and what I know about this particular baby and this particular parent, and how we can make those connections. And also to remember that suffering, there is always suffering or pain under the rage. And we are going to try to seek out the benevolence in the conflict. You know, when we see that this mother is not responding in the way we think she should be responding to the baby, we need to have some type of empathy and asking the question, why? What is the meaning that the mom is not responding to the baby? To be benevolent about that and to offer kindness and encourage hope. Okay, so this is it. And now I would like us to have we have a couple of minutes right now to be able to have a discussion, and I would like to hear from all of you a little bit about how it was for you to hear all this information. Or if you think that is going to be a way in which this particular information is talking about the type of work that you are doing, or if you will be able to include this information in the work that you are doing. I would like to hear a little bit about you.
Yes, definitely. I think that learning about, so many, like working in a child care, you're working with children in your daily lives. So I think even as mothers, even if you're not a professional, I think this will definitely help like me to get the social cues to understand, especially that you were talking about that, that picture about the secure base. It kind of helps me to work when I'm working with children, with working with families, how I can help them and how I can make them understand about, when to let the children go, because I think we want to go and don't give opportunities sometimes to children to explore. So I think, yes, this is definitely very beneficial. I did hear about attachment theories and, but I think it kind of gave me a little different perspective as to, how to even understand children from where they're coming from, how they're crying and then how to help them. So it kind of gives a little different perspective to me. And so thank you so much.
Oh, you're welcome. I'm so happy that the information was useful, And I think that we have here some of the comments. And Leanne, you were saying that it was hard. Like Ellen, it brought back memories when you were young as well, and when you were raising your children. Okay, and I think that this piece is very important. I think that one of sometimes when people ask me, what is exactly what you are doing, Gloria? Sometimes I tend to say, I am creating safe spaces so people will be able to self-reflect in one way or another, and to gain a better understanding of who they are as humans. Okay, and that is exactly what you are sharing with us, that you became aware, not only about you as the child that you were at some point in time, but also to become aware of your relationship with your own children. So thank you very much for sharing that, because that is very important. And I think that the other thing that I would like to point out is that try to be generous with yourself and to see, how this information is impacting me at a personal level, and how this information is impacting me in terms of the type of work that I am doing, and how we can put together the two things, okay? But I think that that is amazing, the ability that you have already to go deeper in a self-understand, to be able to self-understand. That is amazing. And I want to tell you that I am very grateful that you were able to share with us that. And Vina, you said the importance of nurture and supporting the parents in their role, and really thought how important it is that we help parents think about and address goals, the past trauma history. You are very right about that. If we really want to support and to help children to develop the way they are supposed to be developing, we need to work with the parents. We really need to work with the parents and to provide a lot of support to the parents. And then I cannot even, because I have been doing my work here in the States for so many years in dyadic work, I cannot even imagine working with individuals, you know? Yeah, and even if I would be working with individuals, my sense is that I would be bringing all this information in my work with this individual, even if the individual is not a parent, okay? And I think that that also is amazing how, in my case, when I was doing my work in Mexico City, the whole focus of my clinical work in Mexico City, working at the Children's Hospital, was providing family therapy, okay? And now here in the States, I am doing a lot of dyadic work, but I think that, again, is like I cannot conceive a child without thinking about that this child is embedded in a family system and in relationships, okay? And then there is another comment that says that it was very helpful, and also that ACEs should be considered when working with pregnant women. Yes, definitely. We all the time, we are during the foundational phase, the clinical interview with the pregnant woman, we are paying a lot of attention in terms of identifying the different domains of ACEs, you know, and because they are going to play an important role in the way we are going to develop our treatment plan. And also there is a comment that says, I should add, we need to think about our own goals, the past that may impact our work with parents and families. You are completely right about that. You know, when I am supervising my interns and my postdoctoral fellows, you know, because we provide reflective supervision, and we encourage the intern to be, or the clinician to be able to think about why I am having this intense countertransference, intense feelings about this particular baby and this particular mom. Yesterday, I was providing supervision to one of my interns, and she was telling me the mom is having a very hard time right now. The baby is about to be born, and the clinician has been spending a lot of time trying to support mom with concrete things, okay? And one of them is to try to find housing for the mom. And then she told me at some point, the clinician told me, Gloria, and if I cannot place this mom in a safe housing situation, to provide her with a safe housing situation, I am going to take her home. And I said, okay, slow down the process. Let's talk a little bit about why you are having that urge. And she was able to explore, to do a lot of self-exploration about that. So yes, in doing this work, we really need to keep in our mind our own ghosts and our own angels. I don't know if there are some other comments that you would like to do, to make right now.
Hi.
Hi, Angie.
Oh, hi. Hi, yes, I want to say thank you. I was fortunate enough to attend both the English and the Spanish version of this training, and I'm actually in transition to focusing more on 0 to 5. So this has been absolutely so helpful because I'm so used to not focusing on the parent, but working more individually. So it's just been an incredible, and people asked some amazing questions today. So it was just, I'm just sitting with a lot and trying to integrate everything right now. So just thank you everyone who participated.
Thank you, Angie, for your words.
And I'm so glad you're here, Angie. You're the next generation, I think, that's coming in to do this wonderful good work. And I think if you need more information about Gloria and programs she's affiliated with and training opportunities available, I think you can forward them to us and we can make sure we get any information sent to your way. I'm always happy when there's young people that are just.
Beth, I have to share with you that I have met Angie.
Oh.
Yeah, she's an amazing clinician, as you were saying, is the next generation. And I am so excited, Angie, that you are doing this work.
Yes, thank you. You were my inspiration, Gloria.
Oh, thank you. Thank you. You are amazing. So she is the new generation, Beth.
I'm so happy.
Yeah, she's amazing. Mm-hmm.
Great.
And there is another comment that says that Vina is thinking about adding the term angels. So I am so happy to hear that. Mm-hmm. Is there other comments or a question that you would like to ask me before we finish? Oh, thank you, Ellen. You are saying thank you for modeling such a safe and validating space. Yeah, because thank you, because I think that that is what all of us we do. You know, we are creating spaces in which we can start feeling safe to talk about sometimes very about difficult things that our families with whom we are working are going through, or even ourselves, you know, because these traumatic experiences are going to, is part of being a human being. So how we are going to be able to cope with them is what is important, okay? Thank you, Leanne, for mentioning that you learn a lot and that you think that it was very interesting. I really appreciate that. Thank you.
Yes, thank you. And thank you, Dr. Castro, again for being here. We so appreciate you. Look forward to having you back again soon to have more conversations about mental health and perinatal mental health. And for those of you, thank you so much for being here, for attending. Be sure to complete your evaluation. That really helps us a lot to know what more you want. And this work and this good work that you do, that's the only way we know if we're getting it right. So filling out the evaluation helps us a great deal. And the pre-surveys give such good information to the trainer. So we're going to go ahead and say goodbye for today and have a wonderful weekend. Look forward to seeing you at another training soon. And again, Angie, thank you so much for being here.